cloud. Okay, so tonight I wanted to talk about platelet-rich plasma therapy, what we're going to refer to as PRP. And before we sort of delve into what it is and how we use it, I want to sort of point out several things. That even though the purpose of the talk tonight is introduced how we can use this therapy to augment what we already have available to us when managing cases of osteoarthritis or degenerative joint disease. I want to point out that this has actually been a therapy that's been around for quite some time. And, many companies produce products that allow you to extract platelets from the blood. There were, periodic publications which supported its use, excuse me, but it never gained a tremendous amount of traction. Certainly, it almost certainly gained more traction on the human side. And it sort of appeared on scene roughly around the same time that stem cell therapy became an option. Whereas stem cell therapy has really never lived up to the promise, probably because, we don't yet know how to, if you will, program cells to do the job of rebuilding tissue. PRP, which, mind you, is a much less expensive option than stem cell therapy ever was, is just now one additional tool in our armamentarium to help manage patients. And we'll talk about some other sort of clinical indications for its use as well. But it was here, but admittedly, there was a lot of problems. So there were problems with the consistency of, the product that we were producing when we were doing it in hospital. In other words, the number of platelets we were getting, whether there were certain other cellular contaminants that could cause a problem. So it's now we decided to sort of bring this back for two main reasons. One, there's a body of literature now that the veterinary community can get behind and confidently say, yes, there's enough evidence to say this is a valuable tool for managing osteoarthritis and some other conditions in veterinary medicine. And at the same time, we no longer have to be responsible for producing the product from a patient's blood. We have actually, there's several companies that produce the product and do all the quality control necessary to ensure that we're getting a consistent product and one that's free of any of the contaminants that we would worry about. And it also makes it a less expensive option now that we don't have to do the legwork and risk, obviously, not producing a product that's ideal for the patient. And so this is why we're now talking about it again when we, it's been a number of years, since we've had these types of conversations. I think one of the first things to sort of mention here is, to talk a little bit about what a platelet does, because the first thing I'll point out is a platelet is not actually a cell. You could really more correctly think of it as sort of a piece of a cell, if you will. For instance, it doesn't have a nucleus. There's no DNA in it. It can't reproduce itself. And most people think of platelets as, that part of the blood that's responsible for clotting blood. And of course, that's, as you can imagine, a really important function that it serves. But beyond that, the platelet actually does have a variety of other functions. And I would sort of generally categorize those functions in two ways. One, the platelet has the ability to sort of act in a way that it sort of constructs a scaffolding, if you will, when tissues are damaged. Not just like a physical structure that allows the migration of cells and cells that are obviously going to repair the tissue and blood vessels, but it helps stimulate that process as well. Obviously, if you didn't have platelets involved in the process of tissue healing, wounds, even the smallest wounds, wouldn't heal very well. And they do some of this because even though they don't have like a metabolism as a true cell does, they do contain, what we refer to as granules. So they do contain a lot of compounds that, when released from the platelet, help to cause a migration of, basically the building blocks necessary to repair tissue. And those granules contain compounds that have various names, and I don't know that's necessarily important for this conversation, but it is important to recognize that platelets are a very key element in getting tissues to heal. Without them, tissues of all types in the body are not going to be able to repair themselves. Now, when it comes to what we're really going to sort of move into and talk about today, PRP, I mentioned this before, but I think it bears repeating. This is not a situation where we're going to administer this therapy and see tissues regenerate. We're talking about this more as a palliative measure, meaning a way of, for all intents and purposes, managing pain and inflammation. And believe it or not, that's really what all of our therapies do, whether we're talking about drugs that we use to manage osteoarthritis or even some of the new immunotherapeutic options. It's only in situations where, for example, you might replace a joint, like a hip, for example, where you're removing all the damaged components and replacing them so you do not have a consistent source of pain or inflammation. And that's important because I don't want it to don't want people to think that, hey, we do this and somehow these platelets are going to magically repair a damaged joint. That's not going to happen. Now, I've mentioned so far, the possibility of using platelet-rich plasma therapy to sort of manage osteoarthritis. But there's a few other conditions in which it's used. But admittedly, the evidence, if you will, we have for use of PRP is greatest with respect to osteoarthritis or degenerative joint disease. But it's at times been used for wound repair. It's been used for certain types of procedures that one would do in the mouth. Excuse me, when you have things like periodontitis. And the way it got its start, the way that the PRP sort of came into the veterinary lexicon was actually on the large animal side when it came to having to manage ligament and tendon issues in large animals, which I think are probably a bigger problem, say in the horse, for example, than they are in the dog. And right now, and I should have mentioned earlier, we're really talking about PRP with respect to canine patients. We don't yet have a commercially prepared product for cats as of yet, although you could use some of the kits that are available to extract the platelets. But if we're really talking about the evidence point towards its use in dogs. Now, how does the process work? So we talked just a few moments ago about the fact that the platelets act as a scaffolding. Think of the platelets as, in some ways, acting like a canary in the coal mine. They help to stimulate the body's immune system and let the rest of the body know, hey, there's damage here. We need to come in and repair this. And when we used to talk about this in the past, we used to have to talk about extracting blood from dogs, using these various tools to then distill or remove or concentrate platelets before we could then administer them. But now we use a commercially prepared product. And what's particularly relevant about this, and again, it's one of the two reasons why we can sort of reintroduce it to our clients, is the fact that they actually take platelets, what are called pooled samples. So they have multiple different dog donors that are contributing to this pot, if you will. And they're able to screen out some of the contaminants, even some of the things that are normally part of blood, like certain types of white cells or even red cells, which have been identified as sometimes being disadvantageous with respect to getting tissues to heal. We also have the ability of having a consistent product in that we know how many platelets we're administering, because when we talk about platelet-rich plasma therapy, one of the downside is there's still no standardization that exists as far as what constitutes a PRP product or at what level we should be concentrating the platelets relative to the concentration that's actually present in the circulating blood. As a general rule, we look towards roughly anywhere from about 2 to 6 times the number of platelets should be in the PRP product versus what would normally circulate in blood to get the desired response. But it is also a situation where if you put too many platelets into the product, it actually can have a deleterious effect on tissue healing. So having this consistent product now makes it viable. And from the standpoint of being able to provide it, it's something that literally is in sort of a vial that's dried, and we sort of mix up or reconstitute it when we need it. The other thing is, because we have a consistent source of platelets, excuse me, we have the ability within one session to potentially treat several different joints. This is a treatment, a therapy that is administered directly into the joint with a needle. As you might imagine, pets are not just going to sit still for this. However, it's not something that by and large requires general anesthesia. Sedation, even a little bit of numbing locally is sufficient to be able to perform the procedure, because due to the size of the dog, for the most part, it's very easy to access the joint spaces where we need to administer the product. And in those circumstances where it's a little bit more challenging, perhaps like in the hip joint or even the shoulder, we can use things like ultrasound or even x-rays to help us target the needle so we can administer the product. Now, because we are injecting something into the body, we do need the patient to be still. So sedation is required, but at the same time, we treat this as a very sterile procedure. So, we're not just slapping on a pair of exam gloves, giving it a quick wipe down. We prepare the site of injection the same way that we would prepare a site before performing surgery to minimize the possibility of contamination. And that's really probably the greatest sort of downside or side effect that we would warn people about, is that the platelets we're introducing are highly, highly improbable to cause a reaction by the body's own immune system. The greatest risk anytime you put a needle into a joint is introducing bacteria, which would find the environment in the joint a very nice environment to grow, replicate, and cause an issue. But when done correctly, the risk is truly very, very low. One of the caveats that's important to keep in mind, and of course, this is something that gets a lot of press with respect to people in preventing heart attacks, is that a lot of the common anti-inflammatory medications we use, like for instance, carprofen in veterinary medicine, or even aspirin on the human side, have the ability to inactivate platelets. Remember, we talked earlier about the fact that platelets carry these little sort of sacs or granules full of the compounds we need to stimulate tissue healing. And either in the process of administration or preparation of the platelets, if we get sort of premature activation of these granules, we may not get the response that we're looking for. And so there are some medications which, we have to be careful with. Now, there isn't a lot of literature to say that this is an absolute no. As you might imagine, a lot of patients who would undergo this therapy might be receiving one of these medications like Rimadyl or carprofen. But it doesn't seem at the moment like we probably have to discontinue use of those drugs. However, to be on the safe side, what I would oftentimes do is use an alternative type of medication to manage the slight discomfort a patient may feel for a couple of days due to the, at the injection site. Platelet activity is going to be at its greatest roughly within the first day or so after the treatment is administered. So it's probably safe to say that after a few days, or a few days after the procedure, we could then proceed to getting back to using one of these medications that would otherwise, perhaps adversely affect the platelets we're administering. I'll also point out that with one of the newest therapies that I know you're particularly familiar with, Renee, Librela, it seems to be compatible. There's not a contraindication. And we often find ourselves in a situation when it comes to, say, osteoarthritis, especially when it's generalized, is in order to get the best response, sometimes we have to combine the action of different therapies in order to really improve the patient's quality of life. Or as they sort of progress in life, perhaps the initial therapy we're using is no longer sufficient to provide the relief that they're looking for. And this is where, PRP becomes an option. Now, I did mention, as I said, this goes directly into the joint, but it's not something that has to be limited to a single joint. That is, of course, one of the advantages of having a product that we now have easy access to, is that we can potentially treat multiple joints in a patient at the same time, which in the past was a bit of a challenge because you never quite knew what type of platelet yield you were going to get when we did the work of extracting the platelets. Certainly in cases where you have a patient that might have, arthritis of its hips or a couple of bad knees, we now have the flexibility, or at least the option, of treating several joints simultaneously in the same session. The actual time spent administering the injection for most joints is actually no more than a minute or two at best. It's a very, very quick procedure that they undergo. Now, of course, one of the sort of first questions we get asked is, well, okay, so what's this going to do? How long is this going to have a positive effect? Well, to be fair, one of the first things you have to realize is we're not going to be able to estimate or necessarily quantify the response a patient is going to have until we actually administer the therapy. There's no predictive test, if you will, that we can use. And the same thing can be said for the response. In the literature, we find that many patients can get 3, sometimes 4 months of benefit from the one administration. Are there patients that can make it for a longer period? Are there patients that don't get quite as much relief? Absolutely. And this is, as a biologic product, there's a little bit of uncertainty here because a patient's response can not only be influenced by the product used, but again, in this case, it's standardized, but also by the patient, what conditions they might have, their age, the degree of osteoarthritis they have, and of course, whether they have any underlying conditions or they're on medications that might affect the way the product works. So there is an element of uncertainty that goes into using this, and you have to be comfortable with that measure of uncertainty. As I said at the outset, the risk of complications or side effects is exceedingly low. So it's very unlikely that we're going to do any harm. But the degree to which we actually improve the patient remains, a bit of an open question until we try. That said, certainly in those patients that do have a favorable response, it is something that you could administer again in the future. It would be nice, if we had, a year at a time, but the reality is that's not likely to be the case. And so there are those patients that may need serial injections, perhaps several times a year, to maintain the response, as they age. Now, the hard part, and another caveat that goes with the therapy, is that we know a lot about the use of PRP. Of course, as I said earlier on, there's not a sort of a standardized protocol. There's not a standardized product or guidelines for a product that we can use as a reference point. And so again, it's just, I'm mentioning this point because it just adds a little bit to the uncertainty. And you might say, well, why on earth would you even consider this type of product? Well, there are certainly circumstances where patients have osteoarthritis and they have other conditions. And using some of the more common medications to treat the arthritis may conflict with medications that are administered for other conditions. You may have a patient who just doesn't tolerate the meds well, or an owner that's not really interested in a pharmacologic option, but is interested in a more natural option. Or, as I said earlier, this just may be a situation where we need something else to augment the therapy that a patient is already receiving. Certainly in situations where you have a patient where you can clearly define perhaps one or just a couple of joints that are more severely affected, you might get a better response since you could focus this therapy on those joints alone rather than having to administer, a systemic therapy, a drug, for example, that may not be the best fit for the patient. So, these are all things that kind of go into the calculus of whether the PRP would be right for a particular patient. So yeah, thank you for the question. So PRP has actually been around, oh my God, I'm going to say roughly at least 10, 15 years in some form. Early on, unfortunately, it was very difficult to make an apples to apples comparison with respect to the published studies because you had different technology that was used to extract the platelets, and you had different protocols that people used in practice to administer the product. And of course, the third consideration was the difference in the patients that were selected to be treated. And again, this sort of gets back to this uncertainty I was referring to. It's an option because, as is so often the case, we can minimize the risk to the patient. As I said, the greatest risk, and albeit it's a small one, comes with the actual administration of the product. One thing to keep in mind, which earlier on was a concern, is whether, and I should say that this actually played into some of the discussions around stem cell therapies, was whether when we extract the platelets, do we do anything to manipulate the platelets chemically in some way? And could that then lead to a problem like a cancer or a tumor down the road? And in this case, we do not. It's a very natural, clean product that we're reintroducing into the patient. So there are some clear indications where it's a consideration, but as I said at the outset, it's just one tool in our armamentarium to manage pits who have osteoarthritis. Now, aside from DJD, which is clearly the best studied indication and the condition which we have the most information about, there are those patients, as I said, who will have certain wounds, or patients who may have significant periodontal disease that may also benefit from PRP therapy. And believe it or not, patients that can have a lot of bone damage, the PRP has the ability not just to recruit sort of soft tissue elements, but help in bone repair. And therefore, some people have at least considered looking at it for the possibility of as a partial treatment, if you will, when repairing a fracture. Which leads me to another, and perhaps the single biggest indication, and that is its use in knees when a patient has torn its cruciate ligament. The cruciate tears that we see in dogs, by and large, probably have more to do with how their knee is put together rather than sort of a moment in time, say, for example, one that a running back might experience on the football field, where the body goes one way and the legs go the other, and they have sort of a sudden traumatic tear. And so people have looked at using not just PRP to help try to repair some of the damage, which as of yet doesn't seem very likely, but both shortly after surgery and then as far as sort of maintaining the level of comfort in the patient, using PRP to manage the inflammation, ultimately the pain that they can experience. And at least in the case of dogs, when we address a cruciate tear, unlike on the human side, we don't ever restore the normal anatomy. There were procedures described many years ago, which have sort of fallen to the wayside. So the procedures that are most in common use these days augment the joint, but they don't restore its normal anatomy. And therefore, all of these patients are destined to get some measure of osteoarthritis. And so at times, there are people who are actually treating these same patients when they get surgery. And then at some point later, again, trying to deliver a treatment specific to the area where it's needed most without having to potentially, in some way adversely affect the rest of the body. And so this is probably the leading indication at the moment for use of PRP in patients with osteoarthritis. Truth be told, I was going to actually use this in my own dog, Rosie, up until a couple of weeks ago, because she did tear her left ACL a number of years ago and has a little bit of arthritis in it. But unfortunately, she tore her right ACL. And so she had corrective surgery here just a few weeks ago. So I'm waiting until the right knee heals completely before administering the therapy to her left knee.
Hey, Josh, I do have a question. My dogs are on the Librela, so I'm a little confused. When do you diagnose or recommend using this therapy versus what I'm on with my girls as they age? Or is this something you piggyback together at some point? Just trying to understand when you choose that versus the other options available.
So a couple, I think, important things to it's a good question to recognize. Number one, Librela is what I would consider to be more of a systemic therapy. In other words, it's not specific to any particular joint. Librela works by sort of knocking out a compound that sort of signals pain to the nervous system. So it blocks transmission of that pain signal, and therefore recognition by the dog that, hey, my knee is painful. Again, it doesn't do anything. The Librela does nothing to repair the joint, and you're sort of blunting or interfering with that pain signal. It still exists, but you're not sort of aware of it. And it's based on an antibody. We call it an immunotherapeutic because antibodies are part of the immune system. So I would look at PRP as a companion, but certainly in a situation where we have a dog who has sort of a generalized problem, I think Librela can probably now be classified as one of the now 4 things that are evidence-based when managing patients with osteoarthritis. And I think that for a lot of patients is becoming a sort of a first-line mainstay. I think that perhaps PRP maybe has its greatest value in patients that have osteoarthritis, but are either dealing with a particularly problematic joint, one in particular, like for instance, in my dog Rosie's case, she had some arthritis, she's 10 years old, but she suddenly damaged her cruciate ligament. And rather than put her on medication all the time, I could, and mind you, she's already on Librela, I could treat the issue she's having in one particular joint. Could you make an argument for using PRP as a first-line therapy? Sure, you could. I think a lot of it's going to come down to, the individual patient, what the owner is comfortable with. And keep in mind that one of the limitations in both cases, actually, this is one of the sort of shared issues, is that neither therapy, neither the Librela, for example, or the PRP is going to provide relief indefinitely. They have to be given on a continuous basis in order to, produce the desired therapeutic effect. At least in the case of Librela, there was some concern about some possible adverse reactions. And in truth, if you give the product to enough dogs in this country, there is going to be a small percentage that have an adverse reaction. You could, in some ways, make the same argument about PRP. But I don't know that it's necessarily a question of, or rather that we have a very strict algorithm at the moment that says you have to do this first and then that. I think the decision to treat, or the decision about what to use to treat, it comes down to in sort of the individual conversation you have with the owner, and is also determined by what other conditions or issues the patient may be dealing with. including, admittedly, some of the cost considerations. Some of these products, like Librela, are not inexpensive. You, for example, have 2 very large dogs. If hypothetically we had one of those dogs that just had one bad knee, it might actually be, if we strictly look at the numbers, more cost effective to manage that knee issue with, say, PRP than Librela on a monthly basis, just because of the cost relative to their size. So I think there's a lot of considerations. I don't think there's a rigid algorithm that we would use to make that decision.
Okay, thanks. And is there a certain age that it will not be effective anymore, the PRP therapy?
No, I don't think we can say that. I mean, I think if anything relating to age, I think you could look at a situation where perhaps a patient has very severely advanced osteoarthritis, and maybe say, you know what, under the circumstances, this may not give us the level of relief considering the expense and what's necessary in order to administer it. And therefore, we might need to consider other options. But I'm not aware of having seen any literature that says, okay, after this point, a patient cannot receive PRP. And again, we're not using general anesthesia, so the risk of even using a mild sedative for the overwhelming majority of patients is going to be exceedingly small.
Okay. Thanks, Josh. Appreciate the education.
So I didn't want to belabor this point, or rather any of these points, but I wanted to provide sort of a brief overview of what this looks like and what's involved, recognizing or at least acknowledging that there's still some uncertainties that exist, both with respect to what type of response that we can expect and how long that response is going to last. But recognize it again, it's just one additional tool that we have that allows us to sort of individualize, or, for lack of a better word, customize the therapy that we're offering to patients who do have osteoarthritis. And certainly in situations where we have, wounds to address, I will say that just, in sort of an analogous way, for years, we've used extracts from blood serum to help us heal things like ulcers in the eyes, or even, certain types of wounds. So there's sort of anecdotal precedent for this type of therapy, that goes back many, many years. But now we're finally seeing sort of a more sort of a strict evaluation and consideration of where it would be most beneficial and how to provide it to maximize the therapeutic effect. So with that, I want to thank you for joining us. And obviously, we're going to post this on YouTube, as we always do. But if you do have more questions about it, feel free to reach out at the hospital and let me know.
Josh, have a good evening.
Thank you.
You're welcome.